Hello and welcome to the second of our ESGE live video endoscopy webinars. My name is George Webster, and on behalf of my colleague Gavin Johnson and our team at University College in London, we are delighted to be showing a few cases over the next 90 minutes to really inform discussion about a topic that we deal with every day of the week if we're involved in biliary disease, which is the assessment and management of biliary strictures. We are absolutely delighted to be joined by a fantastic international faculty, including Jeanin van Hooft from Leiden, Christian Gerges from Düsseldorf, Marianna Arvanitakis from Brussels, and Helmut Messmann, president of the ESGE from Augsburg. We're also going to inform the discussion by reminding us all about ESGE guidelines related to this important area. So we're actually going to start with the first case. And this is a 61-year-old woman who unfortunately has liver metastases. At presentation had an unknown primary, but in fact had obstructive jaundice with no visible mass, but with imaging consistent with a low bile duct stricture. And the aim here at ERCP was to relieve her biliary obstruction, but also to obtain tissue for analysis. So the case, in fact, is being performed by one of our fellows, Simon Philpotts. So let's go straight to the case.
Another little go, see if we can skip up under there. That looks very good. Nice and gentle, that's good. Okay, where's that? That may be very good. That's very nice. Okay, so it's quite an angulated bile duct. I'm sure that's being related to the mass, isn't it? Very, well, it's a very shouldered stricture, that, isn't it? Good. And you would just want to be sure that it's the common hepatic duct isn't being separately nipped. And if you can pull an 11.5 or 15 millimeter balloon from common hepatic down to the stricture, then we're happy. I mean, sometimes that can be because the chronically dilated bile duct can be a little bit folded, can't it? Yeah, injection's not so important, really. Oh no, it comes through there. That's quite interesting, isn't it? I think that's probably just folded. Well, low CBD. See if we can drive that through. It's tight, isn't it? It goes around a bit of an angle, doesn't it? There you go, good man. So it's a little bit of an angulation with at that point of stricture. We saw that when you passed your wire, didn't we? It's a very tight stricture. No, that's nicely through. So we're using the Infinity brush supplied by Steris, which we'll look at it in the workshop. So the advantage of this brush is it has stiff. Yeah, just that's good. It has stiff bristles, front and back, and then soft bristles in the middle and the. So there's quite a shouldered stricture here. So we're just going to use an endobiliary biopsy here. Now it's a tight stricture, this, so we really don't want to discard or lose our wire because it's a very tight stricture. But I think we should be aiming, as a general rule, to use more than one modality to sample indeterminate strictures. That's good, and then just advance on that. Very nice. And so these over the way, they're a little bit tricky to pass through the sphincter, aren't they, Simon? Because the actual very tip is proud of the just proud of the wire. So one needs to be a little bit careful of that, but that's fine. And then we carefully come out that, and you've got the wire still in place. Good. And now we can go straight in with the stent now. So we're going with an 8 centimetre fully covered Cook Evolution mesh metal stent. Okay, that's good. Screen, please. Very good. Okay, good. So we're up high. That's fine. We can shorten that as we come back. Yep. We just wondered a little bit about that point in the common opaque, didn't we? This will open up very nicely. So draw back a little bit. There you go. Into the. That's beautiful. Draw back there. Nice. Okay. Don't draw back anymore now. Start to keep deploying. It's going to open very nicely in the upper part. That's it. Draw back a little bit more. Very nice. Now you just need to worry about the lower point now. Can we just come down the patient just an inch or two? Okay, that's fine. You're in a good position. Just it's a perfect stent position. So backward tension, and keep deploying. Okay, pin out. Yeah, don't come back too much now. You're okay. Yeah, very nice. Beautiful. Beautiful, very nice, well done. Yeah. So that's perfect. Don't take your wire out until you're totally happy, but you are, aren't you? And lovely dark bile draining out. So that's a super procedure. Screen, please.
Okay, sort of case we see quite frequently, and Simon Philpotts is going to remain centre stage, one of our excellent fellows, by presenting the ESG guidelines on tissue sampling as applied to ERCP.
My name's Simon. I'm one of the pancreatobiliary endoscopy fellows at University College London Hospitals. This short presentation will take you through the relevant recommendations on biliary stricture sampling in this 2021 ESG guideline on endoscopic tissue sampling. I have no complex to disclose. So if we start with pancreatic solid masses, ESG recommend FNA and FNB needles equally for sampling solid pancreatic masses. Since the 2017 ESG guideline on EUS tissue acquisition, there have been a number of RCTs and meta-analyses that have compared FNA and FNB needles, and they are equally as good at sampling pancreatic masses, and the diagnostic yield does not differ. However, other studies have shown that sample adequacy for histological evaluation is higher, and fewer passes are needed with an FNB needle. As such, ESG do suggest using newer generation FNB needles when the aim is to obtain a core tissue sample. As most of you know, 70 to 80% of bile duct strictures are malignant due to either cholangiocarcinoma, pancreatic cancer, gallbladder cancer, metastases or lymphoma, and there are a number of other benign causes. On the whole, diagnosis can be established with just a basic workup of imaging, including ultrasound or MRCP, ERCP with standard transpapillary sampling such as intrabiliary brushings, and in the case of patients with pancreatic masses, EUS FNB or FNA may be needed. For patients where diagnosis isn't reached, we term this an indeterminate stricture. The options we have available for sampling indeterminate strictures include cholangioscopy, which has a high sensitivity and specificity for indeterminate strictures. And this study from 2020 compared ERCP brushings to cholangioscopy guided biopsies and showed a significantly higher sensitivity and overall accuracy. Another option is endoscopic ultrasound guided biopsies. Again, compared to ERCP and brush cytology, EUS guided sampling of indeterminate strictures has a higher sensitivity and diagnostic accuracy. ESGE do recommend using per-oral cholangioscopy for assessing proximal or intrinsic indeterminate strictures. And for cases with distal or extrinsic strictures, EUS guided sampling is preferred, but with peroral cholangioscopy where this is not diagnostic. Here's the full title of the paper, and thank you for listening.
Okay, great. So we've seen a case, we've seen the guidelines, and now delighted to welcome for discussion my colleague Gavin Johnson, Christian Gerges, and I hope that Jeanin van Hooft is with us as well. Great. So, you know, lots to discuss. This is what we see every day. Before we get on to tissue sampling, Jeanin, sphincterotomy. So we knew from the outset that this patient was going to need a stent. They were going to need tissue sampling. Should we do a sphincterotomy in this case?
I'm happy you asked me that question. I think you can read my mind. At the top of my paper is written sphincterotomy, question mark. Yeah, I think it's debatable. Normally, even if I don't have a tissue diagnosis yet, I often stay away from doing a sphincterotomy, just do a cannulation and do a smaller brush. That's also a possibility. Yeah, you choose now the infinity brush. And for the infinity brush, I fully agree, you need a sphincterotomy, otherwise you won't get it in. And I think that the jury is not yet out which brush is better, either the infinity or a smaller brush. They're conflicting data. Actually, we did a randomized controlled trial, data coming out soon, hopefully. So sphincterotomy, that's not my standard procedure in this patient. I would just consider to go for a smaller brush and to go indeed also for a fully covered stent. That's also the question from the Q&A, why a fully covered stent? And I would consider either a plastic or a fully covered stent in this case, preferably fully covered if you have good imaging. If you still don't have good imaging, I mean CT or MRCP and MRI, then I would consider plastic, because especially the MRI is grossly hampered by the metal stent.
Okay. Okay, and just another question for you, Jeanin, on the technicality of doing the cholangiogram in that case. We've got prior imaging. Do you do a balloon cholangiogram to define the stricture? We were a little bit worried there. The proximal bile duct was very dilated, and there appeared to be what we interpreted, I think, correctly as a fold in the middle of the bile duct there. But would you, as standard, do a balloon cholangiogram, or would you be happy there to say, we've got the pre-procedure imaging, we just do the sphincterotomy, we define with a little bit of contrast, and then we go with the stent? Or do you think we need to delineate the duct above the stricture?
Yeah, I would go for delineating, but I should consider to do that with just a catheter over the wire, get up higher, give a bit of contrast, and then I think this tumor might have been visible. So in this case, which is exceptional, I would not directly go with a balloon. Well, normally I tend to do lots of cannulations just with the balloon because I think it's very helpful if you have a good occlusion cholangiogram. Okay.
Great. Gavin, your view of the tissue sampling, you know, and I'll bring Christian in on this as well. Would you say that the days of it being acceptable just to wave a cytology brush and that be enough are over? And you know, of the choices we have, what would you choose, or would you choose all available?
Yeah, so it's a very real problem. The patient's here presenting with jaundice, so they need decompression. We could talk about in the context of pancreatic adenocarcinoma when you would do a primary Whipple, but in the UK that's a very rare phenomenon, particularly in the post-COVID pressures on HPB surgical lists. Another jury that's very much out is whether neoadjuvant chemotherapy for pancreatic adenocarcinoma is the way to go. I think the jury is about to report, and that might be a trend. And I think that will really shift the emphasis for the initial index endoscopy event towards making sure at the time of the biliary decompression and insertion of what should be a definitive stent with a fully covered metal stent at that point, that you should really go that nth degree to make the tissue diagnosis to guide oncological therapy. We also have found some positive results with the Infinity brush. We're in the middle of auditing how much better it is than our previous very, very disappointing brush cytology from legacy brushes. But it is our practice to pretty much aim to do an EUS for the index just prior to the index ERCP. The results with an FNB are up at the 90–95% mark that you'll get your tissue. I think for this particular case, where there was no visible mass on CT, there's the added advantage of really having an inference whether this is a malignant stricture, as Simon said, 80% likely, versus a benign stricture, and also further diagnosis in terms of tissue. It also means you're not recalling that patient a week or two later, and usually it will mean taking that stent out. Unless there's a plastic stent in, you get reasonable EUS views of the head of the pancreas for distal bile duct strictures. But if that's a metal stent, even if that's a reasonably large hypoechoic mass on EUS, you often are a little bit guessing as to where your needle's going for the best cause. So you end up doing a second ERCP within weeks of the first one. So I think we should be aiming to do an index ERCP EUS with these patients, absolutely. Okay. And that'll be more the case if neoadjuvant chemotherapy proves to be the way forward for pancreatic adenocarcinoma.
Okay, thanks, Gavin. And Christian, endobiliary sampling. We showed here using the over-the-wire biopsy forceps with the histoguide. Do you do, shall we say, freehand endobiliary fluoroscopically guided biopsies, or when we're going to be talking more about cholangioscopy, but for a low bile duct stricture like this, do you reach for the cholangioscope or less so?
So no, for the distal biliary strictures, actually using a cholangioscope might be even a bit of challenging, therefore, and I think your case showed very nicely how good the access was with the biopsy. We changed actually in our unit from multiple use to single use biopsies last year, and I have to say, in our experience, the single use biopsies are sometimes a little bit hard to get into the bile duct, harder than with the multiple use biopsies, but still it is doable, and I think it has a good point when it comes to distal biliary strictures. We always combine, as you did, and I think the results with the brush, when you have such a tight distal CBD stricture, are quite good. We do it a bit differently than you, Jeanin, obviously, because we also always do a sphincterotomy. I use a big brush to get a good tissue, and and then we combine the methods. And interestingly, when you look into the Messmann review about indeterminate biliary stricture, we know that the combined tissue sampling is better than single tissue sampling. But if you look into the subgroup analysis of this, then you will see that especially the brush had very good results in the distal biliary strictures, but not so good in the hilar biliary strictures. And that is actually what we also witnessed in our study that you mentioned when you presented the case, the guidelines, that when it comes to upper or hilar biliary strictures, the brush is not so useful. But I think this is coming in other topics.
We will definitely be discussing that earlier. We'll actually, Jeanin, you've got your hand up in a very formal way, which I'm delighted to see. And we'll come back to you for the discussion after we show the next case. So let's go to the next case. Great discussion so far. So next case, 71-year-old man with obstructive jaundice, with a head of pancreas mass at index ERCP. It was not possible to cannulate the bile duct due to this mass. Biopsies from which showed poorly differentiated adenocarcinoma. So the aim here is to perform an EUS cholangioscopy or duodenostomy, and the procedure actually is performed by our fellow Taz and supervised by our colleague Professor Steve Pereira.
So here we have an endoscopy done by our fellow Taz on a patient with biliary obstruction due to a mass in the head of the pancreas with liver metastases, carcinoma of the pancreas, who has had a failed ERCP because of duodenal outflow obstruction with a tight D1, D2 stenosis down to a few millimeters, which is impassable with anything but a small gastroscope. So he's come back today for an endoscopic ultrasound guided cholangiopathic duodenostomy. And has just demonstrating the dilated bile duct, which is dilated up to 18 millimeters. And behind that, you'll see the origin of the cystic duct at the bottom there, with the portal vein deep to it and the hepatic artery and longitudinal section there as well. So the triad at the liver hilum. So just above the level of the bile duct. So, and from the study, the UK study of 20 patients, which was led by Nottingham, which was published last year. Generally, the figures are 6 millimeter or 8 millimeter at most distance between the bile duct and the duodenal wall. The scope is in a long scope position in the duodenal bulb, and generally that will give you an access which is heading towards the liver hilum a little bit, as you see, and a bile duct diameter of at least 14 millimeters. And we're using a 6 by 8 millimeter Boston Scientific luminal closing stent, the hot axios. So first step is now we're going to do this freehand. So Taz is going to puncture the bile duct. Gentle pressure now. Very good. Then you want to keep going until you get to the inferior aspect just there. That's good. Deploy the distal flange in the bile duct. Very good. Right. Very nice. Okay. Now pull that distal flange up a little bit towards the duodenal wall. Just there. That's good. Then we'll lock that. And then generally we deploy the proximal flange, usually in the scope, making sure that the elevator is off, and just turning slightly rightwards as you're deploying, doing this by endoscopic ultrasound, making sure that the intrabiliary flange remains in the bile duct at all times. Yeah, very good, keeping that view, that's very nice. It's almost there. Good. And then you make sure the elevator is off now. And that's taken a total of about 1 or 2 minutes to get biliary drainage in this patient who's had previous 2 procedures. Good. See the flange in the bile duct? It's already decompressing, I think, and you see the duodenal flange very nicely in the duodenal lumen.
Okay, so lovely, lovely case. So, Jeanin, you can now ask the question you were going to ask, but as well, what should be the next step now after a failed biliary access for distal, a distal malignant stricture?
Shall I start with that one and keep the other just in the pocket? So that's better for my memorizing.
Keep it
the
in
other
the
one
pocket.
I have written. It depends, I think, basically on your center. First of all, if you look at the data, is PTCD the next step after an ERCP or not? I think the data that are out are highly influenced by how much expertise your center has, how financial systems are running in your country. Do you want to keep it all in the hand of the gastroenterologist? I think if you have the possibility to keep it all in your hands and you are very experienced with doing interventional EUS, then I think the next step nowadays after a failed ERCP, so I would not do it straight away, I would first try an ERCP, you could go for an EUS guided drainage. Though they're also starting to come new data from, less experienced center. It's running now more also in community hospitals. And there they see quite a bit of complications of the stent, placing it not in the right angle. So lots of food is getting in. So it's not the holy grail. It's not completely solving all the problems we had before if we could not manage it with an ERCP. And it's no shame to ask your intervention radiologist. So if you are not completely sure that you can handle that technique, either refer the patients or ask your intervention radiologist. If you mess it up, you really mess it up. You have a significant problem if you do a misdeployment.
Okay.
Can I still come back to the other question?
Yeah, go on then.
For the previous patients, one of the questions from the audience was, why not placing an uncovered metal stent, as it looks like already an advanced disease? There are already liver mets. I think the problem is a bit that you do not know the cause. Imagine it's a very well treatable disease, like for example, a colonic cancer, where patients can really react to chemotherapeutics and compression and lesions can really disappear. Then you have a problem if you have an uncovered stent in. So as long as there's no likely diagnosis of being a malignancy, I would try to stay away from the uncovered stents. There are enough lawsuits where we did put in uncovered metal stents and in the end it appeared not to be a malignancy, and then you're really into troubles.
Yeah, and I think we would completely agree with that. You know, everything looks certain to be malignant until it's proven not to be, you know, and we've got a whole collection of patients, sadly, from elsewhere who have got IgG4 related disease, presumed to be hilar cholangiocarcinoma. We've had patients who've had TB of the head of the pancreas who have ended up with an uncovered stent. So, you know, I really think that our take home should be never, ever, ever to put in an uncovered mesh metal stent, particularly across the liver hilum, without absolute confirmation. Christian, of course, you know, Jeanin was debating where the financing goes, but of course in Germany, in Dusseldorf, you're the guys who also do the PTDs. So just very briefly, in your practice now, you're not conflicted from a financial point of view. What would you go for? Do you go for the PTBD or do you go for the EUS in a case like this?
Yeah, thank you for this question. I hope Jeanin doesn't hate me after this because we do it different. We have everything in our hands, and when we look at the Lancet study that was stopped because of the high complication rates when it was compared for ERCP access versus percutaneous access. I was a bit shocked because we don't see this high number of complications in our unit. And when you look into the EUS papers, and then they always say, yeah, the complication rate is similar to the ERCP complications, but then you look into the ERCP complications reported in these studies, and then they go up to 20%. Then I have to ask, well, maybe in a sense, like if you have a lower rate of ERCP complications, your decision would be a little bit different towards the access of the bile duct. So in our unit, we have very good experience to use the percutaneous approach, and our philosophy is that we prefer a natural access or like a natural drainage of the bile duct, because if you create a new fistula with a hot axios, it is not a natural access and not a natural drainage of the bile duct, and you don't know where the future of this patient goes. So for us, we always try a second ERCP if a first ERCP doesn't fail, according like also what Jeanin says. And sometimes, or very often, that already helps. But if that doesn't help, we go and we do it ourselves directly, the percutaneous approach, and that is usually successful. And then you can have a natural drainage of the bile duct. So that's our approach.
Great. And Gavin, there's some.
May I add that I'm not offended, not at all, but what I try to do is to translate it to the general practice and not to the high excellent centers as we are ourselves. So that was my reason to give a bit broader answer.
Great, thank you. Gavin, great question come through about the impact of duodenal obstruction. And I suppose a couple of questions. Jeanin, I know, has a concern about food being held up and then perhaps draining into, through the hot axius, particularly if there is, distal obstruction. And also the overall question of, the reason often we're not able to do the ERCP, as in this case, is because the patient also has duodenal obstruction. Does that, number one, enter the decision-making process when you're thinking about an EUS CDD, and secondly, a subject for another day perhaps, but EUS gastroenterostomy in the setting of duodenal obstruction?
Yeah, so I mean, first of all, we do quite a few CDDs. We brought it in initially for patients who are very likely to be palliative, so a good age, patients who are probably not going to get their Whipple or are presenting with advanced disease. But it's patients with advanced disease are also those that are likely to have either active duodenal obstruction, so gastric outlet obstruction, or potentially imminent gastric outlet obstruction. So by definition, they have large volume disease, and their survival is probably not going to be so marked. But you're quite right. I would be very reticent about doing a CDD via EUS in the context of gastric outlet obstruction, because that patient's not going to do very well for very long. So I think if you're doing that and you suspect gastric outlet obstruction from careful review of the CT scan, often there's clues on the index scan that there's a large gastric contents with duodenal compression. So you should be able to sort of troubleshoot it and guess whether there's likely to be duodenal obstruction. And if that's the case, almost certainly a palliative patient by then, in terms of that cancer being at least locally advanced, if not metastatic. Then if you're concerned about getting in by ERCP due to duodenal obstruction or infiltration, then we would consent for EUS guided biliary drainage at the time of the index ERCP. But like Jeanin, we would always try an ERCP. But if there's also duodenal obstruction, we would proceed to a duodenal stent there and then as well. You'd have to be pretty happy that this is malignant disease, of course, which we've already talked about. At the moment, our rescue therapy for gastrojejunostomy via EUS and lumen-opposing metal stents is reserved for duodenal stent failure. That's just how we've sort of got it through in terms of our governance systems at the hospital, due to cost, time, interventions, pressure on lists and everything else. So we're not the most experienced unit compared to some, which I think in their units, EUS gastrojejunostomies are replacing duodenal stents in the context of malignant disease. But Jeanin and Christian may have other views on.
Well, actually, thanks, Gab. We'll move on to the next topic. We're going to ease our way up the bile duct in a completely artificial sort of way, and present the third case if we can. So this is a bit of a change of tack. This is a 66-year-old man who had a liver transplant a couple of years ago, and has an anastomotic stricture. And curiously, and we maybe can comment about this briefly, stones below the stricture. And we're not going to say a lot about the management of the bile duct stones because of the topic today. And we're going to focus on endoscopic management of the anastomotic stricture. So let's go to the case, please.
So this chap we've discussed had a previous liver transplant and has been admitted with quite significant cholangitis and with imaging showing an anastomotic stricture and, rather oddly, a significant stone not above but below the stricture. And our plan now is to get rid of this stone and then manage the anastomotic stricture. Let's see what we got here. Lots of debris to come out, down with the balloon. So the question for us is, take that from me, what here is stricture and what is... No, I think that's still stone there. Screen, please. Screen, please. That's good. Okay, let's, there we are, there's the stone. Open. Oh, wait a minute, yeah, that's good. Yep, open. Okay. So I can get the basket around that. You're fully open with the basket, yeah? Okay. Let's close now on the basket. Okay, so we'll advance the sheath now. And the sheath is now passed over the plastic sheath. That's good. And as I do that, I want to keep the stone in the middle of the duct, not at the bottom. And I need to avoid the anastomosis as well. Screen, please. Very, keep going. Okay, good. Happy. Right, now you can close the ratchet up on this. Yeah. Yeah. And now and we screen, please. Keep screening. Yeah, and we crush in the middle of the duct. Yeah, keep going. Okay, good. Lovely. Screen. So that's that stone above that. Down with the balloon. That's better, that's better. That's better. So that's that anastomosis. Take that. Right, that's very good. So we've cleared that stone. That's good. No, there's resistance there. Down with the balloon. I don't want to cause mischief there. Screen. Blow up again. Yeah. And inject. Take that. Okay, fine. So that's let's now have the CAFIS stent, please. Anastomotic stricture, I think, does need more management. And so we're going to insert a 4 centimetre by 10 millimetre CAFIS stent, which of course is a fully covered and therefore removable mesh metal stent that is particularly of use for high and benign anastomotic strictures, particularly post-transplant actually. And there may be the other members of the faculty may want to comment further, I know. Okay, so it's inserted over a long wire. There. So 3 markers, one at the top, one in the middle, which ideally should be where the stricture is, and then one at the bottom. Good. Okay, good. So let's start deploying now. Screen, please. We'll do this under screening. Screen, please. Excellent. Good. And let's slowly. That's fine. Good. And let's slowly deploy. Screen. So I'm just taking my bridge off a little bit, and we work together. Stop. Nice and slow. That's fine. And I want the proximal end, of course, to be below the liver hilum. So it's opening nicely there. Stop there. I think the proximal end is in a good position here. Yeah, keep deploying. Yep. Stop. I think we're pretty good here. And then I think you can just keep going. And it'll open. Ping. That's open nicely there. Take that picture. I'm going to slowly come out. Well, you're fully deployed, aren't you? Screen, please. You can keep going, but we're just going to come out now and let that string release, and then we're good. And we just want to see that string falls down. Very nice. And then that, just to say that string is now sitting in the duodenum, and so in 3 months or so, when that stricture is remodeled, we'll bring him back and remove that stent.
Okay. All right. We're going to go. Before we discuss all things stents, we'll go into a presentation by Taz Menabawey, one of our fellows, on the ESG guidelines on stenting.
Good evening, ladies and gentlemen. My name is Tareq Menabawey. I'm a senior registrar at University College Hospital in London, and I've been asked to talk to you today about the ESG guidelines on endoscopic biliary stenting. These are my disclosures. So first of all, we're going to talk about malignant extrahepatic biliary obstruction in the preoperative setting. And for this, ESG recommend against routine stenting for preoperative drainage. And this should be limited to patients with cholangitis, severe symptomatic jaundice, or delayed surgery, or before neoadjuvant chemotherapy in jaundiced patients. And this is on the basis of 10 meta-analyses that have looked into this. No differences in mortality were found between the two groups, and indeed 9 found the same levels of morbidity. 2 retrospective studies on endoscopic preoperative drainage have found that those that underwent it actually had a shorter patient survival versus those without drainage. If it is to be considered, one would recommend endoscopic over percutaneous, and that has been shown to be associated with longer survival and lower recurrence rate. And similarly, if undertaking ESG, recommend the placement of a 10mm self-expanding metal stent over plastic, and again this has been shown to be associated with lower reintervention rates and, crucially, does not compromise your R0 resection rate. Now, in the context of palliative disease, ESG recommend that decompression of malignant extrahepatic biliary obstruction is performed via ERCP rather than by surgery or percutaneously. And primary biliary stenting has been compared with surgical biliodigestive anastomosis. There are less complications associated with the ERCP, but less reinterventions associated with surgery, although one RCT has shown no significant difference between the two. Now, when comparing ERCP versus percutaneous approaches, there are lower adverse event rates with ERCP, and it's also been shown to have a lower cost and shorter hospitalization, and this is on the basis of 2 RCTs and 1 national database. ESG does recommend SEMS insertion for palliative drainage over and above plastic stenting, and that has been shown to be associated with longer survival, lower risk of stent dysfunction, and the reduced need for re-intervention. Now, crucially, if there is unclear etiology as to what the disease is, ESG does not recommend the use of uncovered SEMS because in general they cannot be removed and are associated with long-term morbidity and mortality if inappropriately sited and subsequently proved not to have cancer. Now, for hilar strictures, very difficult to treat, ESG does recommend assessing the resectability before any endoscopic stenting has taken place because of the artifact that can impact on your accurate staging. They do recommend performing the drainage of malignant hilar strictures in high volume centres. As we all know, these are complex cases, and in case of failure you want early access to percutaneous drainage approaches, which tend to be in these hepatobiliary centres. ESG recommends against routine preoperative biliary drainage in patients with malignant hilar obstruction, similar to extrahepatic biliary obstruction, and if it is undertaken, done on a case-by-case basis within a well-considered MDT. For palliative drainage, ESG suggests palliative drainage of malignant hilar strictures by means of ERCP for bismuth 1 and 2, and PTD, or a combination of PTD and ERCP for bismuth 3 and 4. PTD is more frequently successful in bismuth 3 and 4, with similar adverse event rates reported than ERCP. And your bilirubin will drop more than 50% if there is either up to 33 to 50% of liver volume recommended to be drained. If there is less than this, it may not be worthwhile undertaking the procedure. Now, during palliative drainage, one should try and minimize the opacification of biliary ducts that will not be drained, and there are ways in which this can be done. ESG does recommend the use of uncovered SEMS for palliative drainage of malignant hilar obstruction with lower rates of stent dysfunction and a higher success rate. Now, in terms of benign strictures, 1/3 of these tend to be from chronic pancreatitis, 1/3 from post-OA liver transplant, and 1/3 from other causes such as post-cholecystectomy. Similar odds ratio for stricture resolution and adverse events and recurrence with multiple plastics versus metal, although obviously you get fewer ERCPs with metal stents, and ESG recommends the insertion of multiple plastic or fully covered metal for the treatment of benign biliary strictures. For plastic stenting, this should be placing the maximum number of stents every 3 to 4 months for up to 12 months. And in metal stenting, an 8 to 10mm stent, leaving in situ for up to 6 months for the chance to resolve the stricture.
Okay, and so welcome back, and I hope that Marianna can also join us. That's great. So incorporating the guidelines, incorporating that first case. And a great question that's come through on the chat from Carlos Gomez. Marianna, he has asked, in the setting of an anastomotic stricture, why use a fully covered metal stent? Why not multiple plastic stents?
Well, it is a good question. We've got quite a lot of research that already done in this to answer this question. And we know that fully covered metal stents have already shown that they're as good as multiple plastic stents, and that they do require fewer ERCPs to kind of calibrate that stricture. In both cases, you really have to keep a kind of like a list of these patients and call them back and really be sure that they come back to have their stents exchanged, because cholangitis in this setting could be dramatic for these patients. This is really important. But in anastomotic strictures, this was not really the best group of benign biliary strictures. It was the chronic pancreatitis patients one that had the best results. This was still kind of like, the results were good, but they were not the best group to have the metal stents. It's still open to debate. Even the recent meta-analysis that still showed a bit the same thing, that's comparable in the results regarding stricture resolution, but and less stents for less stents exchange, less ERCPs for the metal stents. And also cost effectiveness also is better, but again, it was the chronic pancreatitis patients that were studied more than this group of anastomotic strictures. So I think it's still both techniques can be performed.
And just sticking with you for a brief follow-on question, there's often a question about with wherever we're using multiple plastic stents, is it a case of leaving the first one in and adding another, and then adding a third, and then adding a fourth, or, you know, mindful that by the end of that first plastic stent may have been in for 9 months or 12 months, which is something we don't like to do, or after we've got 2 stents in, for example, when the patient comes back again, do we take those 2 out and put 3 back in? What's your practice in?
We change everything. We change everything. Yeah, we change everything. But it's true that finally, it's not necessarily the patency of each individual stent that resolves the problem, but it's the accumulative diameter of all these stents, and the fact that the bile probably passes between the stents. But we prefer to be on the safe side and put every 4 months to change everything and put an additional stent to kind of build up in diameter and to have a stent resolution, a stricture resolution.
Okay.
But maybe cost effectiveness, it might be maybe a bit less good if you change all the plastic stents every time.
Yeah. Okay. Great. We might actually move on to that. We're going to come back to these questions about stenting, but let's move on to the next case. Lots to get through, and then we'll come back for further faculty discussion. So this is a case of a 62-year-old woman with obstructive jaundice. She's been shown to have some small stones in her gallbladder and has a mid-bile duct stricture. This, she's had an index ERCP at which the stricture was defined, the negative brush cytology, and a 10 French plastic stent was placed. And she has been referred back here for a further ERCP with cholangioscopy to assess this indeterminate stricture. Thanks.
This patient was referred with a history of obstructive jaundice with a common hepatic duct stricture on imaging and stones in the gallbladder. An initial challenge with spyglass was, despite a sphincterotomy, inserting the spy scope, and so as we quite often do, I performed an 8mm balloon sphincteroplasty following sphincterotomy. That then allowed the much more straightforward insertion of the spy scope. And in the common hepatic duct, we saw this polypoid lesion, friable, concern that this may be a polypoid tumor. but of note on careful advancement above this lesion, there was a stone. And it was clear that the polypoid lesion was, in fact, a rather evaginated distal end of the cystic duct being carried into the bile duct by this stone. One can certainly see the difficulty that the previous ERCP had in defining this lesion. They were very concerned that this was not a stone because nothing would move on balloon trawl, and of course this is a classical Maritzi syndrome. Maritzi syndrome can be extremely difficult to manage with conventional ERCP, but very effectively managed with spyglass and either laser lithotripsy or electrohydraulic lithotripsy, as we used here. We were able to fragment the stone in the origin of the cystic duct. And then remove the fragments with a balloon trawl, and one can see on the cholangiogram that the previous stricture has completely resolved. Following balloon extraction, following stone extraction. The fragments, stone fragments following spy can be quite fragmented and angulated, and so we quite favour the balloon sphincteroplasty. But one can see the excellent result at the end, and the patient went on to have a straightforward laparoscopic cholecystectomy. Interesting case. Gavin, as well as talking about management of strictures, we're focusing on assessment. This patient had good cross-sectional imaging and no diagnosis of Maritzi syndrome had been made. Do you see EUS as having a role in this sort of case from a diagnostic perspective?
I think it would have helped, because you're going to have a pretty strong indication that there's stone disease there. You're going to see an echogenic lump in the middle of the duct at the sort of insertion of the cystic duct. You're going to have an acoustic shadow. To be honest, it's probably not going to change your strategy that much, because as we saw here, SPY is going to solve that problem straight away. You see a stone. And I think, again, you said we're not talking about stone management tonight, but I think we're going to start seeing cholangioscopy as the sort of go-to management for Maritzi disease. I think that data will emerge definitively. But it certainly helped here. But yeah, if you've got a mid-bile duct stricture, again, it's what's available to you locally, but we would have a very low threshold here to consider a linear EUS before the ERCP, just to sort of troubleshoot the images in and around the middle of the bile duct. Is that a thickened, suspicious, malignant looking stricture, or is it a Maritzi? But this was done without EUS on this.
Yeah, okay. And Christian, the if you were wielding your cholangioscope, would you have, like me, been initially very concerned that this was a polypoid lesion within the duct?
Yeah, it's from the cholangioscopic picture at the beginning. I thought, when I read your previous manuscript, oh, is this right? Is this really a stone? But yeah, it's probably granulation tissue that occurs from the resulting from this high pressure that the stone made. So I think this case really fantastically shows how great your options are when you use spyglass correctly, and how you can, as Gavin said, can solve the problem within the same session. And I agree with you, like EUS would probably have maybe have given us some indications for a stone, but still we would have gone in with SPY. So yeah, I think this is a very, very good case showing that SPY gave us a lot of good options in these cases.
Okay, great. And certainly, as Gavin says, you know, our surgery for Maritzi syndrome is a real challenge, and the you know, the surgeons sometimes find that they're having to do a bile duct resection or bypass, and they very much are favouring us going with cholangioscopy as at the sort of index intervention. Okay, guys, great discussion. You'll be back with us in a bit, but we are creeping up the bile duct now, and let's go for our fifth case. 73-year-old man, long-standing PSC with a rising CA99 and evidence of a new left hepatic duct stricture. And here we are assessing that stricture with ERCP and SPY. Thanks.
This patient had a long-standing diagnosis of primary sclerosing cholangitis and a new hilar stricture extending to the left hepatic duct with a normal CA 19.9. You can see on cholangioscopy that there are areas of normal mucosa, top left, and abnormal nodular inflamed areas, easy contact bleeding, some new vessel formation. As we advance across the liver hilum, these areas persist. And there is an area of more papilliform type abnormality. No high-grade stricture, and in the intrahepatics there was diffuse cholangiopathy. But the question for today is, what visual diagnosis would we give to these abnormalities, including this area in the left hepatic duct? Is this PSC-related inflammation? Is it dysplasia, or is it cancer? The answer on histology was that this was high-grade dysplasia.
Okay, so we'll actually go, we've got another PSC case, but in fact, we'll go pretty much straight into the guideline, if that's available, on the management of PSC, introducing Simon Philpotts again.
It's a summary of the 2017 ESGE and EASL guideline on the role of endoscopy in PSC. I have no conflicts. To start, we're reminded that the primary diagnostic modality for PSC is MRCP prior to undertaking ERCP. The role of ERCP in established PSC is to assess dominant strictures for any dysplasia or malignancy and identify strictures that are suitable for therapy. The guideline recommends ERCP and ductal sampling to be considered in established PSC patients in the case of clinically relevant or worsening symptoms, i.e. jaundice, cholangitis or pruritus, a rapid increase in cholestatic enzyme levels, or new dominant strictures or progression of existing dominant strictures at MRCP. The choice of therapy for stenting is left at the endoscopist's discretion, the options being balloon dilatation. Importantly, the maximum diameter of the balloon should not exceed that of the ducts delimiting the stricture, and repeated dilatations may be needed if the dominant stricture is the cause of the recurrent symptoms, or there is significant increase in cholestasis, and the patient has had a previous response to dilatation in the past. The alternative is biliary stenting, where 7 French or 10 French straight plastic stents are placed across the stricture depending on their location, but these stents must be removed at a short interval to prevent blockage that may put the patient at risk of cholangitis. We are reminded of the 2017 DIL stent trial, a multi-centre international randomised trial that compared balloon dilatation with stenting. This showed no difference in recurrence of symptoms but was stopped prematurely due to significantly higher adverse events in the stenting group with post-ERCP pancreatitis and cholangitis. Complication rates are similar to the general population. However, with a more challenging primary cannulation, it's recommended that experienced endoscopists undertake these procedures. Standard techniques are used to reduce the risk of post-ERCP pancreatitis. However, patients are recommended to have prophylactic antibiotics to reduce the risk of cholangitis. As we know, there's a high lifetime risk of cholangiocarcinoma in PSC in up to 20% of patients, and 50% of those patients may have their cholangiocarcinoma detected in their first year of diagnosis. ESGE recommend that cholangiocarcinoma should be suspected in any patient with worsening cholestasis, weight loss, elevated CA99, and or new or progressive dominant strictures. It's important we note that CA99 may support the diagnosis of cholangiocarcinoma but does have poor specificity. In patients undergoing ERCP, they must have ductal sampling with brush cytology or endobiliary biopsies. And other techniques that may be employed include cholangioscopy, endoscopic ultrasound, or confocal endomicroscopy. Thank you.
Okay, so we actually will go straight into our second PSC case and then come on for discussion. So 46-year-old female, long-standing PSC, but with progressive jaundice, with a hilar stricture and a significant level of concern about cholangiocarcinoma. Previous ERCP, it has only been possible to get unilateral stenting, but based on her biochemical response and the imaging, we not only need to assess this stricture further, but really try to achieve bilateral stenting. So let's go to the case.
As well as assessing this stricture, we really do need to get plastic stents into the right anterior ducts and also into the left duct system. Yeah, so that's that's very interesting, isn't it? I think all we're doing there is filling the right anterior duct system. There we go. Quite a good view of tortuous blood vessels there. There is nodularity. So the further I go, the more abnormal it looks. I mean, I think we do have to say that there has been... So that's interesting, isn't it? So there's stone debris up there in the liver. Screen, please. So advancing through this area, we're now in the right duct system. And completely normal mucosa here. And then we come back slowly into the liver hilum. Here we go, new vessel formation just starting here. Just going to come back here to see. This is all very abnormal, isn't it? Okay. Open. There's a bit of a nodular area there. And close. That's a nice piece. Yep, thank you. Now, what I want to do now is, I'm not too worried about these small little residual stones. What I really need to do is to see if there's any way of me getting into the left duct system. Just wander up here. Right, well that is very, very interesting. I think I may be in the left duct system now. And you can see on the appearing at 4 o'clock is the abnormal mucosa extending into the right anterior ducts, just here. even to the extent I would say that the origin of left is sort of uninvolved. The working channel of the spyglass is 1.2, 1.3 millimeters. You cannot get two 0.035 inch wires side by side, 0.025 inch wire in the left system. And then I'm going to see if I can pass the Olympus VisiGlide 2 wire into the right system. Here we go. Okay. So that's great. So you can see on the screening now that we have two wires across the bifurcation, which would not be achievable without cholangioscopy. Now we will need to very carefully exchange the cholangioscope, leaving both those wires in place. And now you can just come back with the grey catheter screen, and we'll deploy that stent. And there we are. The left. That's great. Now I'm hoping that the right-sided stent will be more straightforward. It usually is. Right anterior stents are usually more straightforward because you tend to be deploying the stent straight up rather than round the corner. Fabulous. And now you can ping out with your grey marker. Screen, please. Really nice. And at the end, we've got both those stents in a nice position, nicely stenting left and right. We've had to use a lot of tricks there, but I think really makes the point that we've got technologies now that allow us to endoscopically, very carefully select ducts that we need to get into.
Great. So now, good to welcome back Marianna, Helmut, and Jeanin. And thanks. Keep all the great questions coming through. Helmut, I'm always struck that in other parts of the GI tract, particularly the colon, of course, we identify patients who are at risk of malignancy, most particularly colitis, and then we endoscopically survey, their mucosa. We know that the risk of cholangiocarcinoma in PSC is even higher than colon cancer in colitis. Perhaps not during your tenure as president, but could you see a scenario in which, with patients with PSC, that we are cholangioscopically surveying the mucosa in PSC, or do you think, it's a completely different scenario?
Oh dear George, why is that a difficult question?
Sorry, that's why you're the president. You're there to answer.
We have so wonderful two experts here. Well, PSC is for sure one of the most difficult diseases to surveil, and the treatment options are also limited. You have either liver transplantation or try resection, but you cannot easily remove, like in a colon, a polyp. So this patient you showed with the high-grade dysplasia, what is your option? Now, I don't think this is a young lady. She needs a liver transplant, or at least a resection if it's possible. So no way to ablate this lesion by RFA, like we do sometimes in the Barrett's esophagus, where we can do every 3 months a routine endoscopy. So despite we have cholangioscopy now, and you showed this wonderful cases where it really is like a revolution. I'm wondering whether in the near future, a combination with AI can be a helpful guide. So everybody's talking about AI, and a couple of centers, we also do AI developing systems, but this can be an option because still we use biopsy, we use brushing, we use cholangioscopy. It's still some uncertainty, and I honestly, I really don't know how to treat sometimes those difficult cases, and for sure we ask all the other experts, what is your opinion in this situation? It's really a challenge. This is a challenging disease, and the majority are young people. So this makes it much more difficult than if you have somebody who's 80 years old, where we say, well, he's inoperable, and you're limited in your decisions. Yeah.
Great. Yeah, no, thank you. I think we'd all completely agree with the challenge here. And you know, we have talked about cholangioscopy, and here cholangioscopy was incredibly useful to selectively cannulate the ducts. But Marianna, the cholangioscopy in PSC, do you think the visual diagnosis allows us to make definitive decisions, or not?
It's still very challenging. We had this discussion a week ago, I think, where we still don't have all the answers. I mean, even in some cases where you have signs that are definitely suggestive of neoplasia with these tortuous vessels and sometimes even papillary structures. Sometimes biopsies can show no malignancy, and we all have some memories of having patients with benign diseases that had these horrible pictures in cholangioscopy, and we were ready to take them to surgery, and then the biopsies came out with eosinophilia. We had a patient with eosinophilic cholangitis that had this really horrible endoscopic image. So we still need to first of all to have more data on that. Maybe artificial intelligence can help, and then we also have to have we're not in a position that this can be reproducible yet, so we might have different opinions between different experts. So this shows still that that this is still a gray zone.
Yeah, and I think that the study that we did through the European Cholangioscopy Group, you know, of visual diagnosis showed really quite a lot of intra-observer variability. And I think particularly in PSC, you know, I would say that in fact the case we just showed of the selective wire cannulation, in fact, that was a cholangiocarcinoma at the liver hilar. But I can tell you on another day, you know, I certainly with my eyes, I would be seeing a similar appearance in a patient with benign strictures in PSC. So I think it's very difficult. And Jeanin, can we move to the management of strictures in PSC? As is always the case with Dutch studies and the Dutch, you know, the DIL stent 2 came out with a firm, definitive Dutch type of view that, you know, biliary dilatation good, stenting bad. Do you think it is as simple as that in PSC? Should we, you know, not be putting in stents for benign strictures?
No, you know, the answer is not as simple as that. Though I think what it's reset for us is that you should not straight away go for stenting, because I think before that's what was our tendency. And I think with stenting, we also imposed quite some cholangitis, which is very cumbersome in these patients. I mean, as soon as those biliary tracts get infected, we are behind, I would say. So I tend first to try to work with dilation and see if that solves the problem for the patient. Most of the time it's itching. But if it doesn't work, dilating the stricture, I then go to stenting. But we do that also after a multidisciplinary debate, because we know as soon as we start with stenting and you need a further step, for example, surgery, the surgeons want to be involved up front because they do not like it if we make a mess.
Yeah, absolutely. Okay, I think we will go to our last case and then we'll bring everybody back for a final discussion, including everybody's view on the last thing they like to see, the worst thing the thing they never want to see with biliary strictures. But we'll see the last case and then come back. Okay, so 56-year-old man with metastatic colorectal cancer with hilar nodes and intrahepatic metastases with obstructive jaundice due to a hilar stricture. And the aim today, in this case, was to place bilateral uncovered mesh metal stents.
Okay, so this is a 56-year-old man, unfortunately with metastatic malignancy with hilar obstruction due to metastases. Working here with Simon Philpotts, one of our excellent fellows. He's done a good primary cannulation. We've got a nice wire into the left lobe ducts. Oh, do you think? Okay, that's super. I would now go in with your sphincterotome and delineate the left lobe ducts as much as you need to. There's always a debate as to whether you need to do a sphincterotomy. ESG guidelines say you don't, although we are here probably going to put in bilateral uncovered metal stents. Very importantly, we've had a very good look at this patient's MRCP in detail prior to the procedure, so we know that the target here is the left ducts and the right anterior ducts. Okay, good. So we'll leave that wire in there. That's very nice. And now we come out with the sphincterotome. We're going to use a different wire for accessing the other side, mainly to avoid any confusion when it comes to stenting and which wires we're dealing with. Good. So we're recannulating now. Can you blow the balloon up more? Not much is happening there. Oh, there we are. There we are. It's quite useful, that, isn't it? Can you come up the patient just to sniff, please? Screen. Lovely. Nice. Keep injecting. Can we get it in here? Screen. Yeah, good. Okay, good. Excellent. Can we have a 6mm Titan balloon, please? So we're going to dilate the common hepatic duct stricture and into the right here. So we've got wires nicely in both sides of the liver here. Really importantly, before we even started the case, we looked in great detail at the MRCP, and our target was the left and the right superior duct. So it's always a debate as to whether one should pre-dilate these strictures. What we absolutely don't want in this situation is to find that we get a stent in the left. We normally go for the left first because it tends to be the most angulated. What would not be good is if we get in the left and then fail to get the stent in the right. What we're going to do here is to balloon dilate the common hepatic duct and into that right main duct stricture. Because on these balloons, the top marker, which is just in the contrast on the right, which is the proximal end of the balloon. The next marker is the distal end of the balloon, and the third marker is where the wire comes out of the side of the balloon. So we're putting some contrast in here. Very, very nice. So 11 atmospheres is 6mm. Yep, excellent. So quite tight there, isn't it? Let's hold that. I think we will dilate the left as well, Simon. There's no right or wrong, but we don't want to find that you get in there and you can't get it round the corner. Okay, well, let's dilate the left, and then hopefully we just stent. That means that we have absolute confidence that we are not going to lose the wire. Yeah, no, actually, you probably do want to come back, because if your wire is in too far, you then get backward pressure, and it can really affect your ability to advance instruments. Might be difficult getting around this corner. That's nice, that's nice. Little bit further. Screen. Nice. Very nice. Yeah. Lovely, beautiful. So now we go with the 10 centimetre, 10mm Cook Evolution uncovered metal stent. Very nice. Okay, screen, please. Let's stay up close and personal. Now this will be the difficult bit. Do not let your wire come back. It's going to be difficult, this. It's such a difficult bend. This can be absolutely critical, and this is where sometimes we need a super stiff wire, actually. That's interesting, even despite pre-dilatation, it will not get round that bend. So the problem here is that the 025 wire is too floppy. So this is interesting. Because of the angulation of getting into left, we can't quite get the stent to go round the corner over the 0.035 jag. Okay, so what we're going to try and do is change this 035 rather standard floppy wire for an 035 super stiff wire. Now, can you get that round the corner? That's the question. Very nearly there. Beautiful. Right, good. Okay, now, you hold that white tube like your life depends on it, and you pull that wire out. Now, let's have the super stiff. Now, you need to be very careful with this, because if it kinks, we're even more stuck. This may not make a difference, but... screen, please. Yes, perfect. Now you need to put bridge hard up as soon as you're out. Okay, so we're going to have another go here now. So we're hoping that this super stiff amplex wire will stabilize this delivery system to go round the corner. The phrase "so close and yet so far" comes to mind here. So, good. So you saw a great example really of up close and personal as much as you can. Now we can start deploying. Yep, so take the cap off and we start deploying. Screen please. Now you're in a perfect position at the top end. Let's see if we've got enough at the bottom end. So yeah, lovely deployment at the top end. Beautiful. Okay, good. Okay, so excellent. So really good example here of how left-sided stents can be tricky. Now normally the right-sided stents are more straightforward. That's why we always put the left in first. If in this case we had put the right in first, there would have been absolutely no chance of getting that in the left. I think we might have to deploy in this position, and hopefully it gets dragged forward a little bit. I don't think we're going to get it up any further than that. Screen, please. Let's start deploying. Okay, that was 90% perspiration, 10% inspiration. That okay. Yeah, all the way. Yeah. Good. So that's what we like to call the shotgun appearance at the end. Not only aesthetically pleasing, but really important for in the event of needing further ERCPs, because then now we've got access. And take that, please, and both sides draining really nicely. Okay, thank you very much.
Okay, so I wonder if all the faculty could come back on, and I would like you all to have in your minds the thing you, above all else, don't like to see in stricture assessment or management, and you'll have about 15-20 seconds at the end to give your view. Jeanin, clearly the nature of showing a case like that is it was a good case with a nice result. But should we have been doing an ERCP? Or should we, in fact, in this case, have been going percutaneously and letting our radiologists do the job?
I think we should first try ourselves. I think for the patient it's much nicer, especially in a palliative setting, if he has internally draining stents. Though there are, I think even in the guidelines stating if you have a far advanced malignancy, you should go for a PTC. Personally, I always try after a really clear debate with the radiologist about the imaging, and I think you also stated that, because that's really important that you have your, way delineated up front. What can you do and what can't? So I would definitely first go for an ERCP if my team, and that means surgeons, radiologists, says yes, okay, give it a go.
Okay, and I think that I think we would agree with that. One of the real challenges for the radiologists as well is the deployment of the duodenal end of the stents. We feel very, very strongly that we have to have those metal stents accessible outside of the papilla, not too long disappearing down the duodenum, and certainly not, even though it's a hilar stricture, deploying the distal end of those stents above the papilla can make it completely impossible to get back in at another if we need to. And Marianna, with regards to that, what is your approach to stent occlusion? Because at some point, whether it's in 6 weeks or 6 months or a bit longer, these stents are going to block. What is your usual approach in that situation? Do you use radiofrequency ablation? Do you put a plastic stent in? Do you put another metal stent inside the first slot? What would your approach be?
Well, as you outlined, this is fantastic last case. We always try to put the distal parts of the stent in the duodenal lumen, so we can go in easily to both intrahepatic biliary segments, all the intrabiliary segments to clean, to take out all the if there's any sludge or any more soft stones. And if there's ingrowth, we will probably start by putting uncovered metal stents again. And we might repeat this, but sometimes at one point, if there's a lot of stents on both sides and it's getting a bit crowded there, we might start putting plastic stents just to keep the stents patent. But the first step will be to put a new set of uncovered metal stents. Okay,
thanks. And before we get to people's do's and don'ts, Christian, can I ask about pre-dilatation of prior to putting in stents, just in general? Here we pre-dilated the hilar stricture on both sides before putting the stents in. I think we'd have completely failed if we hadn't done that. But generally speaking, what are the scenarios in which you will pre-dilate with a balloon?
Yeah, so I would actually have done exactly the same like you, and pre-dilate the stricture to have a chance to place the stents. And I also do this with benign biliary strictures. Like, I think pre-dilation is always helpful to access the metal stent and to be able to release it. So I personally always try to pre-dilate before I place a stent. That's generally what we do.
And I think that this case was interesting from our point of view, because having pre-dilated, it was still not possible to get that left-sided stent in. And I think we don't use the super stiff wire very often, but I think it can just stabilize the delivery system, in a way that made the difference, made all the difference here.
Well, I have to say that was an absolutely smart move. So congratulations to that, because that really made the procedure possible. And I don't think a lot of people would think in this situation of changing the wire, but they would probably just re-enter with another balloon and then dilate again, and then probably be still stuck. So I think that was absolutely a very, very smart move, and that made the procedure possible. Congratulations to that. And I might just add one comment to Marianna. So what we also like to do is regular RFA in these cases, because my colleagues once said, so what are you going to do now? Are you going to send him home with a stent and let him die? So like we like to get them back and offer them a treatment. I think also from a psychological point of view for the patient, it's important that they know, this is not now like I'm just going to go home and die, but I'm going to like be planned for rescheduled for another intervention, and they're going to try to attack the tumor again. And I think that this is also like another part of
correct. It's, there's some good data coming out that it will definitely prolong the stent patency. So I think it's a good potential there. Okay. Just a quick comment, George, about the stent. The other thing is that most of these fully covered stents, they're the assistant can't help you much with the wire, because it's a short wire technique stent, and there are still some stents that you can put on a full long wire deployment, and that could help you a bit if you really have a tight angle like that. But usually what we would do as well is to put a stiffer wire in this case.
Yeah. Okay. And Christian, in response to your comment about the smart move, of course, if you're pre-selecting the pre-recorded cases, you can show the cases in which you made the smart move. We've kept in a cupboard the cases that we made a very unsmart move, and we're not showing those ones today. Maybe for another occasion. So we're just literally in the last minute, and I want to start with Gavin, and nobody is able to say, oh, I'm agreeing with what they've said. So Gav, what would you say was the thing you don't like to see, or what or must be avoided in stricture assessment or management?
You've hinted at it in those last couple of cases, but it's meddling with proximal biliary obstruction outside of a MDT, or at least a consensus with a radiologist and a HPB surgeon as to what your target is, whether that's feasible endoscopically, and that usually means a referral centre. Proximal biliary obstruction.
Okay, good. Christian?
Sorry, can you repeat the question? Sorry.
So I will. I'll give you 30 seconds to think while I ask Marianna. But the question is, what do you not like to see being done in assessment or management of biliary strictures? And we'll get Marianna. So it's even going to be harder for you now, Christian, because you'll have one less answer available. So Marianna.
Over-injecting all the ducts during the cholangiogram without seeing the imaging first.
Okay, great one. Christian, and then we'll finish with Jeanin.
Ooh,
no, you can't pause. You have to go to Jeanin.
Never had anything in Düsseldorf, no?
Marianna stole my my case, so now
that's no excuse. We'll go to Jeanin, and then you can send it on a postcard, Christian.
No, I think what I don't like to see is a patient with an ingrown, uncovered metal stent in a benign disease. And that is, we've seen a couple of cases, and that is really dramatic for the patients when they get referred to our hospital. So that is really something I don't want to see.
Yeah, great. Really good point. Really good point. And Jeanin?
I really dislike to take over in the middle of a procedure because a colleague suddenly has to go away. You're unprepared, and especially in those kind of hilar stricture, that's what you should never do. You should be prepared. So that's what I hate.
Jeanin, you're the boss now. You don't have to take that sort of thing. So listen, we've run out of time. I hope it's been interesting. It's certainly been fun, I think, for us on faculty. We've had great attendance from people from Europe and beyond. I'm quite sure we'll see the data. So just to finish off, thank you to everybody, and I'll hand over to Helmut to close the session.
Yeah, thank you, George. First of all, congratulations. These were brilliant cases from UCL. Thanks to you and to your team. I know you're an excellent endoscopist, but today I realized you're an expert or an excellent teacher. How you give your advices to your team, fantastic. So I hope participants could learn today a lot. We had really great experts here, and that was the second session of this new webinar. As you said, there's videos, and sometimes it looks like everything is smart, but we can also put in them challenging and troubleshootings. But at the end, it was from my point of view, didactically great. So you covered all the topics, I think, which are necessary in management of biliary strictures. And for this, I would like to say thank you, everybody, and a great thank you again to London, to UCL, where I was as a young fellow, as you know, where I started my ERCP training in the Middlesex. So, okay. So, yeah, for me now is all the time to say good evening, goodbye, without informing you what's going on. If you missed ESG days, you can still, or you could not join every session, please use now the on-demand offer. It's open until June. As you know, we had more than 3,200 participants. It was a great meeting, and it was great to meet all our friends again face to face. So from this side also again, thank you everybody who joined us in Prague. Yeah, and the program on is is now starting for Dublin next year, and Marianna, she is the boss for the scientific program, is working hard with her team. So we can for sure promise the next year the Congress in Dublin will be also very fantastic, and we hope to see you in Dublin in a wonderful Congress Center, which is one of the most modern Congress centers. And yeah, hope there's still some time, and in between you can join a lot of webinars for sure. So and the next webinar is on the June 1st, the advancing role of endoscopic ablation therapies in bariatrics. So it's a satellite symposium supported by ERCP, and you see we have again invited international experts to this webinar. So please join us in June, the 1st of June. And at the end, I'd like to thank those who are working behind, Gabi and David. Without the help, I think this wouldn't run so smooth with meetings and these webinars. And now, thank you again, and have a good evening, and see you soon. Stay healthy. Bye-bye.